We are introducing Sue Ryder Palliative and end-of-life care services today with my colleague Sarah. And then just talk a little bit about where we're located. So we have services in the whole of the Thames Valley area. So we come from South Oxfordshire right to Finchampstead, and includes Thatcham, Newbury, Wokingham, that area. And our team, where Sarah and I work, is the West Berkshire team, and that covers the hospice in Reading, the Duchess of Kent Hospice, and two palliative care teams, one in Newbury in Thatcham, in the community hospital in Thatcham, and the other one is located in Theo in Reading. But for all of that, there is a single point of contact, the number's there, and through them, the referrals are channeled. Mainly they come from GP surgeries and hospitals, but we work in collaboration with other teams as well. So our team has obviously clinical nurse specialists, palliative care doctors, complementary therapists, physiotherapists, occupational therapists. We've got a fantastic lymphedema team as well, and there is a wellbeing and community support team from what I'm part of. Yeah, so that's pretty much our team. And we wanted today to talk a little bit about what we do, because a lot of people don't quite know what Sue Ryder specialises in and what we do. I don't know if Sarah wanted to talk a little bit about this part and maybe take the chance to introduce yourself, Sarah.
Of course, thank you, Marcela.
That's
I'm Sarah Johnston. I'm the head of quality and community services, what used to be known as the head of clinical services. So I'm also the CQC registered manager. I'm a registered nurse by background, and been in palliative care now for about 9 years. So what can Sue Ryder offer? So we have, if we start with our community teams, we have our community teams that are based out. They actually are based out of Theo now, but travel from Finchampstead all the way out to Lambourne. We are lucky enough to have in that team, we have clinical nurse specialists who are prescribers, so they can see patients and look at specialist palliative care needs. These could be symptom control, it could be that advanced care planning piece, it could be end of life care. They work closely with the district nurses. We also have doctors within that team. So if the nurses go out and feel they need additional support, we can ask doctors to visit as well. They are supported by our wonderful occupational therapists and physiotherapists, and they aim to help patients remain where they want to be. So if patients would like to stay at home, then that's what we work towards by bringing equipment in and letting patients have equipment and care at home. At present, we don't have a hospice at home service in Berkshire West. However, watch this space, it won't be long. Having just gone through commissioning processes with the ICB, I think this is definitely on the cards. So when we talk about palliative care, we are looking at those long-term conditions. We aren't just looking at cancer, we are looking at things like heart failure, frailty, and things like that as well. So when we talk about palliative care, people often think just about cancer, but we look at far more than that. We do look at people's last 12 months of life, and as I'm sure you can imagine, with some of the complex chronic illnesses that are out there, that it is very difficult to know when somebody moves from that sort of living with a chronic illness to the approaching end of life. So we do have people on the books that have been with us for more than 12 months. For end of life in the community or in the inpatient unit, we are looking at that management of symptoms in the last weeks or days. And this is where patients move from that palliative care to end of life. We will help them achieve where we can to stay at home with support, especially through fast track funding that we can apply for, that kicks in for the last 6 to 12 weeks of life, and can be 4 times a day care. And as I say, we're hoping actually with hospice at home that we'll be able to do that ourselves, to give the standard of care that we give in the hospice out there in your communities. So the hospice, we have a 15-bedded inpatient unit. All the rooms are en suites. We have visiting 24/7. This is supported by an expert team of nurses who all specialise within palliative care. We have consultants and doctors on the unit as well. So we offer a very rounded package of care, but quite specialised. We also have day services that patients that have complex needs can come into our bases and be looked after for a couple of hours. So we have outpatient clinic appointments, and we have appointments where people can, as I say, come in and spend some time actually having some peer-to-peer support that we find is really, really important, especially for those patients that, you know, are adjusting to a very different way of life. As the slide says, all our services are free at the point of access. This means that if you pay, we all pay into our national insurance, and we are commissioned by the NHS. About 40% of our funding comes from the NHS. The other 60% is actually charitable fundings, hence why you will see us fundraising and shops around the place, because we do need to look at that. A new branch that Sue Ryder has brought in recently is our Grief Kind support. So this varies. We have groups. We have, I think, one in Wokingham on the A4 going out. And then we also have, I want to say another one out that way. We've got one in Newbury, and we're about to open another one in South Oxfordshire shortly. But along with that, we also have all the support online that's available with Grief Kind that actually is fantastic, because if you've ever been there with grief, we know how difficult that can be. Marcela, you haven't got it on there, but can I talk about SGN quickly? You know my love of
course,
SGN.
of course. You've been talking about it all day, haven't you?
I have. So SGN is the Southern Gas Network, and they are actually asking us to promote energy safety out to our client base at the moment. Talk about something called the Priority Service Register, and this is for people who are over retirement age, have children under the age of 5, have palliative illness or long-term illness to register, and it just means that if that power goes off, these people are prioritised. So if they have an air mattress that some of our patients have at home, or specialist equipment, that they will be prioritised being put back on. And we're also talking to all our patients and their families at the moment about carbon monoxide safety as well. So not only are we doing the palliative care bit, we're also trying to help people. I heard a story about somebody who was at end of life, whose boiler went out, and through the SGN network, they actually got a boiler in within 48 hours because they lived in fuel poverty and couldn't afford to replace that. So we're hoping these will have some really positive impacts for our patients as well.
Right, so we want to support people to think about advanced care planning for everyone, people who way before they are ill or diagnosed with any long-term conditions. It's really important to be prepared, because changes in health can happen and at any time to anybody, and it is important to kind of have more resilient communities, and that from the community engagement perspective is really important. So what's an advanced care plan? It is a process, really. It's process of communicating with key people your wishes about your future health and social care, things that are relevant to you, and therefore these things are set and communicated verbally, but also it's good to have them in writing. So these includes things like making a will, writing a statement of wishes, appointing power of attorney, arranging or discussing your funeral, making an advanced decision to refuse treatment, or completing a respect form. Sarah, did you want to cover that?
Thank you, Marcela. So I don't know if any of you know, I've got an example of an advanced care plan here. These were actually used in Berkshire for quite some time, but have stopped being used recently. And the big push is for us to recognise that actually we should all be thinking about advanced care planning, whether that be because you have been given a life-limiting diagnosis, or actually because none of us know what's around the corner. So a big push for Sue Ryder this year is to be looking at those advanced care plans, and to be looking at writing it down informally as to what you would like. So this year we are doing a big piece of work at that. We've actually found a really lovely online site as well, where you can far more in depth than what we kind of do at the moment. So we're looking at that and how we could look at that. So when it comes to respect, and that's really part of this advanced sort of decision making, when patients come on, the first thing, come into the unit or come into that time in life, the nurses and doctors first of all assess capacity, because this is really important. We can't be asking people to make decisions unless they actually have the ability to do so. And if they didn't, then we would be looking to see if they had made powers of attorney and things like that. But let's say they have got, that capacity to make those decisions. We would talk to them about decisions about their treatment when they came in. So it's things like, you have a patient admitted for symptom control and they develop a chest infection and become quite unwell. And with our patient group, that can be really detrimental to them. And some patients want to be treated because actually you can recover from a chest infection when you're well enough and you're given the right treatments. But some people just don't want that. And they say, no, I don't want to be treated. I just want to be kept comfortable. But we do what the patients want. So some people, I sat in a day therapy group when I first started here, and somebody said to me, oh, I've got a respect form. It means they're not going to do anything if I was to pass away. And I said, oh, that's not true. I said, what the respect form says is, if you are to pass away with natural processes because of your disease, they won't do anything if that's what you've decided. However, if you went out today and got hit by a bus, they would still do everything they could in their power to keep you alive. So I think talking to patients and their relatives about what those advanced decisions to refuse treatment or to refuse resuscitation, I think we really need to present it in a way that is understandable, because what we're not saying is we won't treat you. What we're saying is, at this time, this might be the best thing for your health. Do you agree? But we're not imposing, if that makes sense, our views. Unlike when we had the old purple forms, so they would be made in people's best interests. And we don't always have to discuss the decisions on a respect form. If we do with the respect forms, but on the previous forms, we didn't have to, because it was made in their best interest. And sometimes talking to somebody about those best interests wasn't in their best interest to do. Does that make sense? But the respect form has moved it forward, that actually we try and involve people in those conversations, because it's their lives and it's their right to understand those forward plans. Is that all right, Marcela? Thank you.
Perfect, Sarah. Thank you so much for that insight. So because this is about having these crucial conversations, it's important to consider some aspects that you could be perhaps writing down and communicating to family, people that care for you, or people you care for as well. Things like what is important to you or the individuals you care for, such as where you would prefer to be cared for when you're ill and where they wish to die, for instance. So a lot of us don't give it any thought to be, or think, well, it is what it is and it will happen whenever happens. But actually, if we did have a choice, well, which one we would prefer? That is a good thing to communicate. Would I prefer to be at home? Would I prefer you to take me to hospital? Or would you consider hospice care, a particular relative? Things like that. And if you were in a care home as well, how would you like that to be? Information about them, so things that matter to you when it comes to your care, things that you want to keep around you, things that make you feel comfortable. For instance, when I wrote mine, I thought, it would be very strange to have my husband do personal care for me, for instance. So if I had the choice, I would choose perhaps a carer to do it, but other people can feel and think otherwise. So it's the things that I recorded personally. Things like religious views, spiritual beliefs, your beliefs about the afterlife, things that matter to you, who would you like around or not, and very importantly, who would you like to make decisions on your behalf? This is really important, especially if you've got more than one child, or if you've got children from a previous relationship. Things like that is important to consider and be clear about those wishes. And any practical issues, things like, who will look after children, that hopefully will be recorded in your will, if you have dependent children, or who will look after your pets and how to pass on your belongings. So things like that is really important to record. So because we've spoken so much and we would like to hear your voices, it is important for us to, hear your input. So I've put together a little kind of interactive presentation where we can anonymously gather your thoughts. And I wanted to see if perhaps you could join this QR code, which will go to the website to enter this code. And then I would be able to show you the Mentimeter, which is the feedback gathering tool that we will be using today.